Hello, everybody, and welcome to this RPTH Research Recap. My name is Matthew Cormier. I am currently a PhD candidate at Queen's University in Canada, focusing my studies on hemophilia and the anti-factor VIII immune response. I'm currently the social media associate editor for RPTH, and I'm happy to be with you all today. As always, just a comment for those joining us live from YouTube or Twitter, there will be a discussion period for this recap. So if you have any pressing questions for our speaker today, please leave them in your respective chat boxes, and we'll try to answer them in the discussion period after the presentation of the data. So now to introduce our speaker. Dr. Amanda Payne is an epidemiologist in the Division of Blood Disorders within the U.S. Centers for Disease Control and Prevention. She completed her Master of Public Health and PhD at Emory University, focusing on epidemiology, but also has training in basic science. In her work, she has used large administrative databases to answer several public health questions related to blood disorders and their associated complications, including exploring the epidemiology of conditions and evaluating the impact of those interventions. Today, she'll be talking to us about her work that aims to further understand cerebral venous thrombosis and cerebral venous thrombosis with thrombocytopenia. But I will let her tell you all about that. Dr. Payne, it is a pleasure to speak with you today, and I look forward to hearing your talk.
Thank you. Thanks so much for the opportunity to be here and the opportunity to present our work on the epidemiology of cerebral venous sinus thrombosis in the United States in 2018 and 2019. So we can go ahead and put up the slides. All right. So cerebral venous sinus thrombosis, or CVST, is a blood clot that occurs in the venous sinuses of the brain. It's an important cause of stroke in young and middle-aged adults. The mortality rate for CVST has been estimated to be between 8 and 10%. CVST became newsworthy in the spring of 2021 when CVST with co-occurring thrombocytopenia events were reported among persons who had recently received either the Oxford AstraZeneca or the Johnson & Johnson Janssen COVID-19 vaccine. Reports of CVST events following vaccination highlighted the need to understand the epidemiology of CVST outside the context of COVID-19 and COVID-19 vaccination, as limited data were available on the epidemiology of CVST in the general population. Furthermore, although several risk factors for CVST have been noted, information on CVST risk factors is primarily from studies assessing CVST clinical cases reported to registries, without comparison to the prevalence of those risk factors in the general hospitalized population. The epidemiology of CVST with co-occurring thrombocytopenia was largely unknown prior to our publication, with much of what we knew about CVST with co-occurring thrombocytopenia being limited to case reports. So we recognized more recent and comprehensive analyses of the epidemiology of CVST in the general US population were needed to better understand the incidence, demographic profile, and comorbidities associated with the condition. We used 3 different data sources in our investigation: the Agency for Healthcare Research and Quality's Healthcare Cost and Utilization Project National Inpatient Sample, or HCUP-NIS, the IBM MarketScan Commercial and Medicare Supplemental Claims Database, and the IBM MarketScan Multi-State Medicaid Database. In terms of our sample selection from these data sources, for the NIS sample, we included persons of all ages who had a hospitalization in 2018. And for the MarketScan samples, we included persons 0 to 64 years of age who were continuously enrolled in a health plan for 12 months during 2019. We identified CVST and CVST with thrombocytopenia events using ICD-10-CM codes. And for incidence rate estimates produced using the NIS sample, we used the weighted estimate of the number of events in 2018 and the estimated 2018 US population. For incidence rates estimated using the MarketScan samples, we used the number of events identified in 2019 and the total number of persons meeting the sample inclusion criteria during 2019. We also estimated the prevalence of a number of co-occurring and comorbid conditions among persons with CVST and CVST with thrombocytopenia. This was primarily done using the NIS sample, the exception being gender-specific conditions, that were better captured in the MarketScan sample. We compared the prevalence estimates to the estimated prevalence of the conditions among all persons in the sample using the prevalence odds ratio. We identified those conditions using ICD-10-CM codes listed on the inpatient record. This table is an overview of the number of CVST events we identified in each of the samples. The 2018 NIS sample included 1,862 hospitalizations for CVST. These cases represent 9,310 hospitalizations for CVST in the United States in 2018, of whom about 7% had co-occurring thrombocytopenia. The 2019 commercial sample included 418 CVST events, of whom 9% had co-occurring thrombocytopenia, and the 2019 Medicaid sample included 235 CVST events, of whom 5% had co-occurring thrombocytopenia. Adding some context to these raw numbers, overall incidence estimates for CVST from the three samples range from about 2.5 to 3.2 per 100,000 population. Incidence of CVST with thrombocytopenia was significantly lower than the incidence of CVST overall, and the incidence estimates being around 0.2 per 100,000 for all three samples. However, it's important to remember that the commercial and Medicaid samples did not include persons age 65 years and older. In the next few slides, I'll be limiting to the NIS data since that was the largest sample and we're dealing with such small numbers with the CVST with thrombocytopenia group. Incidence of CVST overall varied by age, with the lowest incidence noted among children. Among adults, confidence intervals around the incidence estimates overlap for the various age groups. In comparison with CVST overall, incidence of CVST with co-occurring thrombocytopenia showed a different pattern in terms of age-specific estimates. The highest incidence was seen among children and adults age 40 and older. Sex-specific CVST incidence estimates were significantly higher among females compared with males. In comparison, incidence of CVST with thrombocytopenia did not vary by sex. When we looked at age-specific CVST incidence estimates by sex, we noted males under 18 years of age had higher incidence estimates than comparably aged females. Conversely, the estimate for females aged 18 to 29 years was decidedly higher than 1, the estimate for males aged 18 to 29 years, and 2, the estimates for both males and females younger than 18 years. The incidence estimates were similarly high for females across all adult age groups. In males, incidence estimates remained low at younger ages and began to increase at age 40 to 49 years. At age 50 and older, estimates for males were higher than those for females. We did not have sufficient sample size to look at age-specific incidence estimates for CVST with thrombocytopenia by sex. Comparing prevalence of co-occurring conditions by patient group, as expected, prevalence of co-occurring hemorrhagic stroke, ischemic stroke, and other VTE at another location was substantially higher in persons with CVST overall and CVST with thrombocytopenia compared with the general inpatient population. Prevalence of hemorrhagic stroke among persons with CVST with thrombocytopenia was higher than the prevalence among persons with CVST overall. When we investigated the prevalence of certain comorbid conditions, we noted several conditions are more frequently seen in persons with CVST compared with the general inpatient population. This is demonstrated in this plot with the odds ratio estimates falling to the right of the null line. Prevalence of these conditions was also greater among persons with CVST and thrombocytopenia compared with the general inpatient population, with hemorrhagic disorders and thrombocytopenia-inducing hemolytic or hemostatic conditions having a stronger association among those with CVST with thrombocytopenia. We also noted several conditions were either less common or equally common among persons with CVST compared with the general inpatient population, with odds ratio estimates falling to the left or overlapping the null line. These conditions tended to be the more common chronic health conditions. Regarding sex-specific risk factors assessed in the MarketScan commercial sample, prevalence of pregnancy among women aged 18 to 49 years was higher among women with CVST compared with the general population that was under study. Among 18 to 64 years of age, the prevalence of estrogen modulating medication use was also higher among women with CVST. This difference was primarily driven by women older than 49 years of age. We did not have sufficient sample size to report on these conditions among persons with CVST with thrombocytopenia. Our study has some limitations. Many of the limitations relate to the use of ICD-10-CM codes on the inpatient record to identify CVST and CVST with thrombocytopenia events, and also the co-occurring and comorbid conditions. Other limitations include the generalizability of the market scan samples, sparse data precluding stratum-specific assessments, and limitations related to race ethnicity data recorded in administrative records. Our study leveraged 3 large population-based data systems to report updated information on the incidence of CVST and CVST with thrombocytopenia in the United States. In addition to an in-depth assessment of incidence, the large NIS sample allowed for a comprehensive assessment of comorbid conditions among persons with both CVST and CVST with thrombocytopenia in comparison with the general inpatient population. To summarize some key points, to our knowledge, this study provides the most in-depth assessment of the epidemiology of CVST, particularly CVST with thrombocytopenia to date. CVST incidence varied by age and sex, perhaps driven by prevalence of sex-specific risk factors among women. However, the highest incidence was noted among males aged 65 years and older. Stroke and other thromboses were common co-occurring conditions among persons with CVST, and conditions such as hemostatic disorders, cancer, and infection appear to be risk factors for CVST.
Great.
So thanks for the time, and we're happy to answer any questions.
Thank you, Dr. Payne, for that great presentation. So just a reminder, if you have any questions for Dr. Payne, please leave it in the chat box, and we'll try to get to your question. But to start off, I'm wondering if you can discuss your data in light of the reported incidence of CVST and CVST with thrombocytopenia that have been reported in other regions of the world, and whether or not you can elaborate or talk about the discrepancies potentially, if there are any, between those data, and just in general, how generalizable is the reported incidences that you have found to other regions of the world?
Yeah, that's a great question. So, the first step in starting a project is to look to see what had been reported before. So a lot of what we knew about the incidence of CVST came from largely European populations. So a lot of whom are lacking the diversity of course, the US population. There was a study that used data starting earlier and then going through 2016 using it was actually using the same NIS data, just earlier versions. And they showed an increasing trend. And our estimates match up very closely with what they saw in the 2016 time period. I will say that, I mentioned it in the limitations, our data are limited in terms of being able to assess race-specific estimates. And that's largely because there's quite a lot of limitations using race and ethnicity data that are coming from administrative records. A lot of times those are coming from the medical record themselves and are not entirely accurate, and certainly that's something that requires more work and more study.
Yeah, great. Second question for you is, you present a lot of data about various comorbid conditions that are most prevalent with this condition, and many other data. But of all of this, what is the most surprising finding to you?
I think to us, the most surprising finding around the comorbid conditions was sort of that lack of association that we saw with the more chronic common health conditions. So things like kidney disease and liver disease and hypertension. We tend to, sometimes think of those things as having an impact on hemostasis, but we really didn't see those being associated in our data with CVST. So that, I think, was a little bit surprising to us.
Yeah. And the last question I have for you, is about the clinical practice. So what influences will this data have that you presented here and that you published? What influence will it have on physicians that are caring for patients? How can clinicians use this information to potentially better improve their practice? Is something that they should just keep in mind?
It's a great question, and I think certainly clinical practice was beyond the scope of this publication. I think what clinicians could take away from this is, the paper reports on how rare the event is in the population, but it also, in terms of the comorbidities, maybe pointed to things that that might be considered, risk factors. There's certainly limitations with calling those risk factors because it's not exactly the study design that you would want to use to assess those things. But I think it at least gives them a clue as to things that might be potential risk factors for CVST.
Right. That's great. Well, thank you, Dr. Payne, for presenting your work and giving us more insight into the epidemiology of CVST. So we hope the viewers will read your full report and your paper that is published at the RPTH website. And I hope you will publish again in RPTH. So thank you for presenting your data today. And hopefully the viewers keep an eye out for the next RPTH Research Recap.
Thanks so much. Thanks for your time.